Okay, so good day. Today I will be discussing antivirals with you, antiviral agents. Okay, so I'm going to have to cut this lecture up into several segments. Anyway, we'll just go through it, and I think hopefully things become clearer as we go on. Okay, so let's get right to it. So, antivirals. Viruses are obligate intracellular parasites, and this means that they are entirely dependent on the host cell processes in order to reproduce, in order to live, basically. Okay? So, because of this fact that they are obligate intracellular parasites, for an antiviral to be effective, it must be able to do two things. First, it should be able to either block the entry or exit of the viral particles from a host cell. Second, it also has to be active within that host cell. Okay? Now, because of these two requirements for effective antiviral agents, there are certain antivirals, particularly the non-selective ones, okay, that may interfere with host cell function. And because of this effect on the host cells, these non-selective antivirals will produce toxicities. Okay? So the first generation of antivirals were developed way back in the 1950s, and they are these two drugs, 5-iododeoxyuridine and trifluorothymidine. Okay. Now the problem with these two drugs is that they have very, very poor specificity. And this means that they inhibit both host cell DNA and viral DNA. Nowadays, because of the toxicities of these two drugs, they are only used topically. Okay, so they are now only used topically because in this manner you minimize the toxicities. So there are some principles that are followed when pharma companies look for new antivirals, and primarily the main important thing here is you have to know the mechanism of viral replication of whichever target virus you have, because knowing these mechanisms for viral replication can help identify which are the critical steps that can be targeted by your antiviral agent. So a lot of recent research is focused on the following things. Number one, greater selectivity. As much as possible, you want to be able to really only target infected host cells. Number two, you want higher potency also, because you want your antiviral agents to be very effective. You do not want to prolong the illness of the patient. Number three, these antiviral agents should be stable in vivo while it's being used inside, the body of the persons. And lastly, you want to also reduce toxicities. Okay. So antivirals are virus static, okay? Again, antivirals are virus static. They do not necessarily kill viruses in and of themselves because they only work against replicating viruses. For viruses that are latent, like what you have in chickenpox and varicella zoster, okay, for these latent viruses, and also what you have in herpes simplex, for example, antivirals will not affect the latent viruses. They will only work against actively replicating viruses. So, remember that I mentioned that you have to know the steps in viral replication. Okay, of course, these steps would differ depending on the specific virus, but for the most part, in general, this would be your viral replication steps. Okay, and we'll go through them one by one. For now, if you take a look at the yellow boxes, these are some examples of drugs, of antiviral drugs, and where they act. Okay. So, but for now, we will be focusing on the steps. So first step is viral attachment. How does the virus um, attach to the cell? Okay, so viral attachment and entry. So these can be blocked by, as you can see on the slide, the following antiviral agents. You have enfoviritide, maraviroc, docosanol, and palivizumab. Okay. Next step is entry, viral entry. Okay. Looking at this slide, interferon alpha is a drug that can uh, block viral entry. Okay, and this is used typically in hepatitis B and hepatitis C. Next is viral uncoating. Okay, and this is blocked by amantadine and rimantadine, which is used in influenza. And then you have the synthesis of early regulatory proteins and nucleic acid synthesis. So these are blocked by a number of drugs, NRTIs, which you have in your HIV, HBV, also your NNRTIs, your acyclovir and herpes simplex, excuse me, and foscarnet and cytomegalovirus. And then you have the synthesis of structural proteins, and this can be blocked by protease inhibitors, which is being used in HIV. And lastly, you have viral release. Okay, so this is blocked by neuraminidase inhibitors, which is used in influenza. So we will be discussing the antivirals in this grouping. So we'll start with drugs for herpes. Drugs for HIV is a separate lecture. After drugs for herpes, we'll go into drugs for influenza, and then drugs. Yeah, also the drugs for hepatitis is another separate lecture. So let's start with anti-herpes agents. Okay. So first, let's just have a very, very brief review of the herpes virus. So it is a large encapsulated virus. It has double-stranded DNA. And remember that herpes causes acute infections. And these acute infections are followed by periods of latency. And during these periods, the virus is non-infectious. It stays dormant within the body of the patient. Okay. Now, after these periods of latency, there is periodic reactivation and shedding of infectious viral particles. So the herpes virus group is classified into three groups. You have the alpha group, you have the lymphotropic beta group, and you have a gamma group. And we will be going through them one by one. Take note that alpha group would have your herpes simplex virus 1 and 2 and your varicella zoster, and these would infect epithelial cells. And the latent infection will stay within the neurons. Okay. Your lymphotropic beta group would be your CMV, your human herpes virus 6, HHV7 also, and these would produce acute infection and latent infection in various cell types. Lastly, the gamma group would be your EVB and your KSHV, also your HHV8, and these would produce latent infection in lymphoid cells. So let's go right into the antiviral drugs. So first would be acyclovir. So acyclovir is a guanosine analog. And if you compare the structure of acyclovir here, it looks a lot like guanosine. And the clinical activity of acyclovir is usually against HSV1, HSV2, and varicella zoster. Okay. Now, it also shows in vitro activity against EBV, CMV, and HHV6, but it is comparatively weaker. And if you remember, one of the requirements that we have for antivirals is that it should be stable in vivo. Okay. So for acyclovir, it requires three phosphorylation steps for it to be activated. So it is first converted into a monophosphate derivative by a virus-specified thymidine kinase. Okay. So the thymidine kinase um, enzyme in this case comes from the virus. So this is then converted into diphosphate and triphosphate compounds by host cell enzymes. And because of this, acyclovir is selectively activated. Okay? Primarily because of this virus specified thymidine kinase. Host cells which do not have this virus specified thymidine kinase will not be able to do the three phosphorylation steps required for activation of acyclovir. Okay. So as you can see in this slide, acyclovir's main mode of action is really inhibiting viral DNA synthesis. Okay, so it competes with deoxy GTP for viral DNA polymerase, which will cause binding to the DNA template as an irreversible complex. So once acyclovir binds to the DNA template, it cannot be taken out. Okay, and because it is bound to the DNA template as an irreversible complex, that will be followed by chain termination. Okay, so again, keep in mind, very important, you have your virus specified thymidine kinase to convert your acyclovir into the monophosphate form. Okay. After that, you have the host kinases, which will continue the other two phosphorylation steps, at which it is then incorporated into viral DNA here, and then chain termination later on. So again, acyclovir is selective. Okay, so just to visualize that, so you have your herpes simplex virus entering the cell, okay, and it has its DNA bringing inside into your um, nucleus, okay, and then you have acyclovir here, and you have the herpes thymidine kinase, okay, right there, and the herpes thymidine kinase is what adds the first phosphate group to your acyclovir. Okay. The second and third phosphate groups are added by host enzymes. And that's what you find here and here. So once you have acyclovir triphosphate, this will then be brought into the viral DNA by your herpes DNA polymerase in this step. Okay. Once it is brought into viral DNA, that forms an irreversible complex and you will get your chain termination. Okay? So this table just shows the common uses of acyclovir and the effects that it would have. Okay, so for example, acyclovir is usually given orally. It is used for the first episode of genital herpes. And if it is used, it shortens the duration of symptoms by approximately 2 days. The time to lesion healing shortens that by 4 days, and the duration of viral shedding it shortens that by 7 days. For varicella or zoster, whether it's chickenpox, right, varicella zoster, or shingles, herpes zoster, acyclovir significantly decreases the total number of lesions. Okay? It also decreases the duration of symptoms and viral shedding if you begin your treatment within 24 hours after the onset of rash for chickenpox and within 72 hours after the onset for zoster or shingles. Okay, so that's acyclovir. Bioavailability is 15 to 20%. This is unaffected by food. Okay. There is an IV formulation available for acyclovir. Take note, only one of three anti-herpes is available as IV. So this is used for herpes simplex encephalitis, the IV formulation. It is also used for neonatal HSV and very serious HSV infection and varicella infection. So topical formulations will also produce high concentrations in the lesions, the herpetic lesions. And when it is given topically, the systemic concentration is typically undetected. You cannot, it does not go into systemic circulation. Resistance can develop in HSV and varicella zoster through alteration in the viral thymidine kinase or the DNA polymerase. So if the virus is exposed to acyclovir, there are some forms of these viruses that are resistant. Okay. And if that is the case, then you usually give foscarnet, cidofovir, and trifluridine. And these will have preserved activity against the most prevalent acyclovir-resistant strains of herpes and varicella zoster. So the half-life of acyclovir is 2.5 to 3 hours with normal renal function. But for patients with anuria, this extends into 20 hours. So that's a very, very long half-life. And for patients that are undergoing dialysis, acyclovir can only be cleared by hemodialysis, not peritoneal dialysis. Acyclovir also diffuses readily into most tissues and body fluids. And in terms of CSF concentrations, you get 20 to 50% acyclovir as compared to the serum values. So it is generally well tolerated, very minimal side effects, and the side effects are not that bad. Occasionally, you get nausea, diarrhea, and headache. For IV infusion, sometimes you get reversible renal dysfunction in the form of crystalline nephropathy or neurologic toxicity in the form of tremors, delirium, and seizures. So this can be avoided by adequate hydration and the avoidance of rapid infusion rates. So you have to control how fast you infuse acyclovir. At very high doses, you get chromosomal damage and testicular atrophy in rats. Okay, but there is no evidence of teratogenicity, reduction in sperm, or cytogenetic alterations in peripheral blood lymphocytes. Okay. So the ACOG recommends suppressive acyclovir therapy at 36 weeks in pregnant women with active recurrent genital herpes. So you already give suppressive acyclovir therapy for pregnant women because you're expecting um, vaginal delivery, of course. And if you give this suppressive acyclovir therapy at 36 weeks, then the hope is that by the time the baby comes out, is delivered, then there will be no active genital herpes. So let's move on to the next drug, which is valacyclovir. So valacyclovir is the L-valyl ester of acyclovir, and it is rapidly converted into acyclovir after oral intake. If you remember, first pass metabolism in the liver. Okay. Because valacyclovir is converted into the active form, oral bioavailability, is pretty high, okay? 54 to 70%. And the serum levels of this is 3 to 5 times greater than oral acyclovir. In fact, oral valacyclovir approximates your IV acyclovir in terms of the bioavailability. So of course, mode of action is going to be the same as acyclovir. So route of administration is oral, and the effects you can read on the slide. I'm not going to go through them too much because they are very much the same as your acyclovir. For zoster, though, there is a very important point there that valacyclovir is associated with shorter duration of your zoster-associated pain or neuralgia. So valacyclovir is also generally well tolerated. It has a few adverse effects. Again, occasionally nausea, vomiting, and rash. Rarely, it can cause agitation, dizziness, headache, liver enzyme elevation, anemia, and neutropenia. At high doses, it can cause confusion, hallucination, and seizures. And for AIDS patients that are receiving 8 grams a day, which is the high dose of your valacyclovir, there is increased incidence of GI intolerance and thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Um, yeah. So there is no evidence of increased birth defects when taking valacyclovir while pregnant. So next is famciclovir. So famciclovir is a diacetyl ester prodrug of your 6-deoxypencyclovir, which is also a guanosine analog. So famciclovir is rapidly converted into the active form, which is pencyclovir, again via first pass metabolism. So famciclovir is active against HSV1, HSV2, VZV, EBV, and HBV. Okay. The activation is by phosphorylation, again by a virus-specified thymidine kinase, and this will cause competitive inhibition for your viral DNA polymerase. Take note though, this will not cause chain termination, unlike your acyclovir. So it blocks DNA synthesis, but it will not cause chain termination. Oral bioavailability for famciclovir is around 70%. Again, because it is also a prodrug. Okay, keep that in mind. The intracellular half-life is 10 hours in HSV1, 20 hours in HSV2, and 7 hours in varicella zoster. Excretion is primarily via urine. So the use and effect is again for first episode genital herpes, acute zoster, it is similar to acyclovir. For recurrent genital herpes, you have 1 day usage, which will significantly accelerate time to healing by approximately 2 days. For herpes labialis, it accelerates healing time. And for zoster, just like your valacyclovir, it is associated with shorter duration of zoster pain. Okay? So the prodrugs are associated with shorter duration of zoster associated pain. It is also generally well tolerated. For adverse effects, again, you have headache, diarrhea, and nausea. Testicular toxicity was found in animals after repeated doses. Um, but for men, there were no changes in sperm motility in men receiving daily famciclovir at 250 milligrams twice a day for 18 weeks. Okay, so this was only found in animals. Mammary adenocarcinoma was increased in female rats also, receiving famciclovir for 2 years, and there is no evidence of increased birth defects during the first trimester. So next is pencyclovir. Remember, pencyclovir is the active metabolite of your famciclovir. This is only given topically. It is typically found in 1% cream, in that form, in 1% cream, and it is effective for the treatment of recurrent herpes labialis. Side effects are uncommon because it is topical, but in 1% of cases, there is application site reaction. Next is docosonol. So you can see what docosonol looks like there. It is a saturated 22 carbon aliphatic alcohol. What it does is it inhibits the fusion between the plasma membrane and the HSV envelope. So this is found in a topical 10% cream. Application sites reactions happen in 2% of cases. So because it inhibits fusion between plasma membrane and HSV envelope, what it effectively does is it prevents viral entry. Okay. And because it prevents viral entry, it also prevents the subsequent viral replication. Up next is trifluridine. Again, you can see the picture on the right. Trifluridine is a fluorinated pyrimidine nucleoside. It inhibits DNA synthesis in HSV1, HSV2, vaccinia, and some adenoviruses. It gets incorporated into both viral and host DNA. So take note, it is not very selective. Okay. So 1% solution is given for keratoconjunctivitis and recurrent epithelial keratitis due to HSV1 and HSV2. Trifluridine alone or in combination with interferon alpha is successful in the treatment of acyclovir-resistant HSV. So is this good for systemic use? It is not, because again, it is non-selective. It is incorporated into both your viral and your host DNA. So some new antivirals, you have pritelivir and amenamivir, and these are helicase primase inhibitors. You also have another new antiviral called valomaciclovir, which inhibits viral DNA polymerase, and this can be given for acute zoster and EBV. Okay. So in summary, there is this summary slide here that is available for you. Acyclovir, you have the agents on the leftmost, the mode of action, main use, adverse effects, and other notes on the right, on the far right. Okay, so that's it for anti-herpes agents. Watch out for the next one, which would be the anti-cytomegalovirus agents.